Hello everyone, and welcome back to another Rafael Medina subspecialty episode. Today, our focus will be on clinical reasoning, and for this, we have two CP Solvers legends with us. As a case presenter, we have our dear team member, Kirtan Patolia, who is a PGY-free resident at Cook County Hospital in Chicago. So, Kirtan, I would give the mic to you. Would you like to tell us how you are and what were some highlights that you had last week?
Sure. Good evening, friends. So my name is Kirtan. I'm one of the CBSOS team members, and I'm so excited today that I got the opportunity to present case to Dr. Restrepo. I think all of my team members know that how big I am a fan of any GM CPC cases, which comes like probably the diehard fan, like at 4 p.m. CST on Wednesday. If I haven't refreshed any GM page, then who has, right? So I'm a big fan. So I was super excited when I came to know that Dr. Restrepo has kindly agreed to come to discuss so that we can learn from his clinical reasoning. So I'm so happy for this opportunity, and I am sure it is going to be a great case. I also want to thank Parisha for helping with the teaching today, and Mukund for scribing, and Shema for facilitating. And maybe I can pass the mic to Dr. Restrepo to say hi to us.
Hey everybody, it's so great to be back. Always really enjoy doing these and hanging out and learning with all of you and hearing what crazy case Kirtan has prepared for me this time. So I was telling the crew before you all signed on that the last couple ones have been really tough cases, and that they have to be nice to me this time if they want me to keep on doing these.
Dan, maybe you would like to introduce yourself. I think most of you already, and most of the people here in the CP Solvers community already know you. You are a CP Solvers legend, but tell us something about yourself, what you like to do, especially in medicine.
Yeah, so I'm Dan Restrepo. I am an academic hospitalist at the Massachusetts General Hospital in Boston. I'm an associate program director. And I'm actually also, for Kirtan, I'm actually the newest associate editor of the CPCs for the New England Journal of Medicine. So my first love is diagnostic reasoning, and it's kind of what wakes me up in the morning in terms of teaching and in terms of kind of just practicing medicine. Also, I teach a lot of point of care ultrasound and a lot of physical exam and bedside teaching in general. But my love is clinical reasoning. So always great to get to flex these muscles and to get to kind of work through cases with you all live. I think it's not only is it really fun, I think we all kind of grow from doing these off the cuff.
Amazing. We're so happy to have you with us. Then, first of all, Mukund and Parisa, thank you so much for helping out. Mukund, whenever you are ready, would you like to share the whiteboard with us? And then I think, Kirtan, then you can go ahead and start with the first aliquot.
Perfect. Thank you. So we can get started with the first aliquot, and the title for today's case is The Sinister Trail. And let's get started. So we have a 54-year-old lady who is presenting with 2 weeks of left-sided chest pain. She describes the chest pain as mild in intensity. It is unchanged with exhaustion or any position changes. It is non-radiating in nature. It is sharp and stabbing in quality, and it has never occurred in the past. Additionally, she has been having some productive cough with brownish sputum for last month. And over the same time course, she has been having worsening shortness of breath. She also has diffuse pain all over the body, which is her baseline because of underlying fibromyalgia. And some remarkable negative review of system includes no fevers, chills, orthopnea, nocturnal dyspnea, lower extremity edema, nausea, vomiting, abdominal pain, night sweats, weight loss, confusion. So all of these have been negative. And that's the end of first aliquot. Thank you.
All right. So we're hearing about this 54-year-old woman. She's presenting with sort of subacute development of chest pain, and additional system review is also notable for productive cough. You know, I think the more patients you see with chest pain, the more you realize that sort of the descriptors of pain are sometimes helpful, largely when what I would say the narrative is spontaneous. And I find that spontaneous narrative is probably the most powerful. The minute when you're starting to get into like describing it, asking a patient to describe the chest pain, if they haven't volunteered it, I've just seen like a decent amount of variability in terms of things that we don't classically associate as being sharp or burning with, you know, something that does. And so many times I think the character of pain is a powerful, has kind of powerful positive likelihood ratios, in the sense that, you know, if people volunteer that it's pressure like, or if people like tell you that it's only when they're moving around, or if people tell you that it's worse when they're laying flat, you know, those things are powerful. I find that like when you start having to dig, it's perhaps a little bit less less useful, but still actually critical that we do it. So we hear that we have non-positional, we have non-exertional, we have not frankly, you know, radiating or respirophasic pain, but sort of focusing kind of the left side of the symptoms. You know, this still leaves a decent amount of pathology that really could be causing it. So, you know, I would think about sort of when we combine the Venn diagrams of cough with chest pain, especially a productive cough of brownish sputum, I think we have to start thinking about sort of pleuritis as a cause of chest pain. And so you definitely want to think about kind of pneumonic syndromes, right? Like things like pneumonia causing pleuritis, things like a pulmonary embolism with infarction causing older blood, causing, that same sort of old hemoptysis. Those would be two things that I'd really want to chase down. You know, it's funny, classically, like back in the olden days, it was pneumococcal pneumonia was said to produce a brownish or rust colored sputum. So that is one thing that kind of, whenever somebody volunteers that they are just giving me brown sputum, I do wonder about pneumococcal pneumonia in those cases. And also another organism that kind of has that same sort of buzzword association is Aspergillus. So we'll hear, you know, we heard that she has fibromyalgia, but so much of diagnosis is in the host. And so much of sort of expert reasoning depends on actually identifying enabling conditions as we think about illness scripts. And so to me, obviously, you know, if we're, despite some of the story not sounding kind of at least like ischemic chest pain, if you tell me she's had 4 stents, and if you tell me that, you know, I think the host is gonna, you know, if she's a heavy smoker or has excessive cocaine use, those things are really going to change kind of how our differential diagnosis progresses. But yeah, so I guess at first blush, I would say, you know, want to think about things that cause pleuritis and actually involve the airways if it's giving us some sort of hemoptysis or some sort of productive cough with sputum. So again, PE, pneumonia, other causes of pleuritis, non-infectious pulmonary syndromes, alveolar hemorrhage, things like that. So that's kind of where my brain is going right now, without having too much more information here. Obviously, there's a bunch of don't miss chest pain diagnoses that I think get floated around in all of these discussions. I'm going to not kind of take up the time and go through them. But obviously, you know, those are things that we're going to kind of keep in the back of our heads as we're starting to examine her, ask her some more targeted questions as we learn more about her, and as we get some basic early diagnostics going.
Amazing breakdown of the case so far. Kirtan, would you like to give us the next aliquot?
Sure. Perfect. So as Dr. Restrepo rightly pointed, that host is going to be important. And actually this aliquot is pretty dense because it has so much information about the past medical history. So she has diagnosis of COPD asthma since last 15 years. And for that, she has been taking fluticasone, salmeterol, albuterol at home. And her last exacerbation was 2 months ago. She also has fibromyalgia, for which she takes duloxetine. And her current pain is her baseline pain. She also has ankylosing spondylitis, for which she has been taking adalimumab. The last dose was 2 months ago. In 2011, she was diagnosed with TB sacroiliitis, and at that time she completed 9 months of RIPE therapy, and since then has been doing fine. She also has irritable bowel syndrome that has been going on for last 5 years, and that has been well controlled just with home remedies. Regarding her social history, she has smoked 1 pack per day for last 30 years. And last time she smoked was 2 years ago. No alcohol, illicit drug use, marijuana, or over-the-counter supplements. She is originally from El Salvador, and she came to Chicago in 1998. And since then, she has always been in Chicago. No travel, no pets, no sick contacts. You go and examine her, you see her vitals are unremarkable, breathing fine, looking very pleasant and comfortable. You do the targeted examination and you find that there are reduced breath sounds over the left lung base and there is diffuse wheezing. And that's the only remark you're finding. Everything else, abdomen is looking fine, mentation is looking fine, extremities are looking fine. You get some basic data and you find that her troponins from the ED are unremarkable. You get the CBC, WBC shows 11,000 white blood cells with neutrophilic predominance, hemoglobin 13.3, MCV 90, platelets 353, normal LFTs, normal electrolytes, BUN, creatinine, coagulation parameters, urine analysis, all within the normal range. And that's the end of this aliquot. Thank you.
Okay, so just to confirm, before we dive too much into this, any absolute eosinophil count on that?
So it's normal. No, yes.
Normal. Okay, so no eosinophilia. And then when you say the urinalysis was normal, there's no proteinuria and no cells at all.
Correct.
Okay. All right. So yeah, the host really matters. So now if you're going to make kind of diagnoses a little bit more complicated, all you have to say is that they're on a biologic and that they've had tuberculosis before. And so, and they are from a region of TB endemicity. And they're also from a region that has, you know, histoplasma and other endemic things that can lay dormant for quite some time. So, you know, we're hearing that this is a person with known pulmonary disease. You know, it's my habit to always question the diagnoses of COPD and asthma when I see them in a chart, specifically with kind of people presenting with multi-system problems. So obviously, you know, she has a heavy smoking history. It does seem like she could have actually had true obstructive lung disease from COPD, especially if she actually had asthma before. So, you know, that here may be signal or it may be noise, but it's always prudent to kind of just say, you know, suspected or possible COPD until you actually have pulmonary function tests or clear evidence of emphysema on cross-sectional imaging. So always kind of take that diagnosis with a little bit of a grain of salt before completely like just assuming that this person has COPD. Because if you see somebody coming in with kind of chest discomfort, cough, and shortness of breath, and they're wheezing all over the place, you may kind of call off the search for other different diagnoses if you're going to bill it as a COPD exacerbation at up front. That is a cognitive bias known as search satisfying that we do very, very frequently, is where we kind of like, we hear the first plausible explanation, we turn our brains off, and then we really stop thinking about the case. So that's just one thing. The COPD and asthma may or may not kind of play a role here. If she truly does have structurally abnormal lungs and she is immunocompromised, and you know she does kind of have a host has a nidus for different foci of infection. So coming back to this, you now have an immunosuppressed 54-year-old woman from El Salvador with prior actual like disseminated tuberculous disease, now presenting with kind of chest discomfort and productive cough. And so I think I'll go through this in a little bit in the sense that disproving tuberculosis in this case is going to be exceedingly difficult to do. She's already had it, and disproving TB is really hard in somebody that hasn't already had it. So you can imagine that indices of suspicion in this case in a person with pretty much hemoptysis and immunocompromised and prior TB is going to be really hard to do. We haven't really gotten into diagnostics, but this would be the kind of person that I would be putting on. We'll see her chest imaging in a little bit, but even in this case, if she has hemoptysis and a productive cough, this is the kind of person that I would be going to see in an N95, and I'd consider about kind of airborne precautions up front. And if she's able to expectorate, starting with induced sputa for acid fast smears. So the other parts of you know, in terms of going to see her and the exam doesn't really lend too much to us. I think chest imaging is going to be absolutely critical here. And in an immunocompromised person, I would say that a chest X-ray is probably not going to be enough if you have a CT scan that's actually available to you in somebody that is immunocompromised. So let's always think about kind of the background and how it's informing the foreground. I spent a lot of time already talking about tuberculosis. I think it's probably wouldn't be me getting the same case more than once here, but I'm going to say it out loud again. anything TB can do, histo can do better, and you certainly have a lot of histo that lives in Central America. So whenever you're thinking about TB, you might as well kind of just like throw in histoplasma or any of the endemic mycoses, meaning mycoses that have a geographic predilection, or the ubiquitous mycoses, meaning those that do not have a geographic predilection. So in those cases, we'd be largely talking about Cryptococcus, and we'd largely be talking about Aspergillus. Okay, so you know, I think the fact that she's immunocompromised, the fact that she's had TB, which can kind of create nitises for other infections, or COPD if she does have structurally abnormal infections. Certainly, always infection is going to have to rise pretty high to the top, even if they don't have a fever. That to me is not really good enough to talk me out of infection. When I'm thinking about non-infectious things, we have to really think about you know, obviously structural lung disease, pulmonary embolism. We have to think about things like, you know, in my mind, I'm kind of struggling to connect the ankylosing spondylitis to the to any sort of kind of pulmonary pathology. You know, folks with AS can get aortic insufficiency. They can get a lot of restrictive lung disease from sort of a stiffening of their spine. But I don't think of ankylosing spondylitis and the spondyloarthropathies as like a strong kind of pneumotropic disease as how it predisposes her for something like an ILD. So in that case, I think it's probably more the treatment for that condition that is the enabling condition as opposed to the condition itself. And I think I saw something in the chat about paracoxy. That's a lot more further down in South America, the way I think about it. At least I may be wrong here, but those are the things off the top of my head. Again, I think we're obviously going to get a chest film here, but I worry about kind of stopping at just the chest X-ray in her. So without totally committing to a diagnosis, we have an immunocompromised person that's had prior TB. To me, it's going to be like infection at the top of it, and then we can start to think about the non-infectious stuff down at the bottom.
Amazing reasoning sharing. What I'm curious about, you were asking for the EOS at the beginning. May I ask you why?
I am an eosinophile. So I love eosinophilia. It's like one of my favorite clinical problems. Beyond the fact that I just like it, it's actually a very useful pivot point. So pivot points are sort of facets of a case that have limited differential diagnoses, right? Like chest pain, long differential diagnosis; dyspnea, long differential diagnosis; eosinophilia, not that long, especially when you use kind of Venn diagrams and you think dyspnea and eosinophilia. So it's a powerful pivot point. It can whittle things down. And so it can increase the chances that this could be, you know, something like an infection that's associated with eosinophilia, like parasitic infections or fungal infections, allergic responses to fungi, like, you know, ABPA, which sometimes causes hemoptysis with, you know, sputum in a person with asthma. And so eosinophilia is actually a rather useful kind of case here. Whenever there's sort of a question of, is this asthma or eosinophilia? Is this a COPD exacerbation? I start encoding asthma mimics in my brain, and EGPA, or eosinophilic granulomatosis polyangiitis, the disease formerly known as Churg-Strauss, is actually is an asthma mimic. So I always kind of think about it. Most of those folks at presentation, unless they're on steroids, show up with eosinophilia.
You mentioned ABPA. Would you like to share with the audience how this is being diagnosed?
Certainly. So allergic bronchopulmonary aspergillosis it's disputed as to whether or not this is an actual infection and whether antifungals are always kind of indicated in this case, but it's largely in people with atopic predispositions and longstanding asthma. And it's thought to be an allergic response to the actual presence of aspergillus in the airways. Clinically, it presents with sort of, again, wheezing, dyspnea in an atopic kind of host with variable amounts of productive cough, kind of like a bronchiectasis type picture. And it also, as I said in the first aliquot, has been associated with kind of a rust-colored sputum or dark kind of sputum. On imaging, we do see bronchiectasis and we see airspace disease in the upper lobes. You also will see kind of diffuse tree and bud nodules. So in these cases, it's actually an indication for intensification of immunosuppression, and first-line treatment is actually kind of treating an allergy to this fungus by usually corticosteroids. And I think I'm not an expert in this, but afterwards, antifungals are utilized. On labs, many of them have a peripheral eosinophilia, and they actually also have a very high total immunoglobulin E level, and they also have Aspergillus specific immunoglobulin E titer positivity.
Thank you so much. Then Kirtan, would you like to share the next aliquot with us?
Perfect. Dr. Restrepo is killing it. I'm loving the discussion so much. All right. So as you rightly asked, that in immunocompromised host, we are not going to get away with X-ray. We will need chest CT. So X-ray was obtained first. It did show that maybe there is a tiny effusion in the left side of the basal aspect of lung and some hazy opacity. So we obtained the CT chest to better characterize it. And we found that there is a small left lower lobe subsegmental PE without right heart strain. There was left lower lobe consolidation with air bronchograms and small left pleural effusion. We tried to tap it, but it was too small, so we couldn't tap it. So at this point in time, she was still doing fine. She's on room air, not hypoxic. But then on day 2 of the admission, she starts becoming hypoxic and she rapidly progresses. So like you start with the nasal cannula, doesn't work. So you consult MICU for high flow nasal cannula. And despite being on like 60 liters and like 90% FiO2, she's still saturating barely at 92%. So she's becoming more and more hypoxic. At this point in time, you again do the bedside focus. So again, there is no change in effusion size. You still cannot tap it. And what has been going on regarding management so far? So she receives the ceftriaxone and azithromycin because of concern for community-acquired pneumonia. And now that she is in ICU, her case qualifies as severe pneumonia. So she starts getting hydrocortisone 50 milligrams every 6 hours because of severe pneumonia. And meanwhile, her pain also intensifies. So she gets hydromorphone, ketorolac, and morphine along with this. Despite all of this, she has no improvement and keeps on worsening. And then we reached the day 5. And since she keeps on worsening, we thought that it's time to get repeat CT to see if there is any changes. So I have some images which I can share with you. And then I can also share the official interpretation.
Okay, before we go into that, can I ask a quick question? So,
Please.
So it looks like some lower lobe unilateral airspace disease, a small subsegmental pulmonary embolism. All right.
Correct.
To confirm. And 2, how comfortable was she throughout all this with this degree of hypoxemia? Was she tachypnic? Was she dyspneic? Or was she kind of like chilling?
So she was dyspneic, but she was not tachypnic. Like her respiratory rate barely went to like 21, 22, but she was more and more hypoxic on the labs and on like your pulse oximeter.
Okay. And this was before the interval the interval imaging, she's now still on high flow.
That's correct.
And it's been maybe a few days on ceftriaxone, azithromycin, and steroids at this point.
Perfect. So we are currently on day 3 of ceftriaxone, azithromycin, and stress dose steroids. And since she is still on high flow and almost to the verge of getting intubated, that's why we are now getting the repeat imaging. So today is day 5 of hospitalization.
So one thing we need to think about before we, look at our pictures, right? Even if our picture hasn't changed, let's just, before we kind of reinterrogate her parenchyma, because one hypothesis here is that her worsening gas exchange is because she has a progressive parenchymal process that we just didn't catch on our first set of images, and she has clinically changed since then. The other is that maybe this is all we're going to get and the picture is going to be exactly the same. I'm just going to posit to the group, does a subsegmental PE and one little lobe being down cause this degree of hypoxemia and respiratory failure? The only one I would say, the only way this would be possible is actually if there's a comorbid shunt, if that's present. So, and typically, and it's not always the case, but many times when people have shunt physiology, the reason I was asking Kirtan this is because they tend to look very comfortable, because hypoxemia itself is actually a very bad driver of dyspnea. Really, it's usually the stuff that makes you hypoxemic that makes you dyspneic. It's something filling your lungs, water or pus or blood, right? Those things make you short of breath. The hypoxemia itself is actually a very, very, very bad driver of dyspnea, unlike PCO2. The minute PCO2 goes up, people start trying to huff and puff. But hypoxemia, very bad driver of dyspnea. So sometimes when we have shunt physiology that's been open, which can actually happen with a bad pneumonia, it can happen with a pulmonary embolism. If you acutely raise right-sided pressures, we can open things like a PFO, and you can actually have significant right to left shunting and large amounts of hypoxemia that actually are refractory to oxygenation therapy, which is kind of the classic manifestation of shunt physiology. So if I suspect that something's going to change in the picture, but if we didn't have something changing in the picture, I think it's really important to always, if you hear rapidly progressive hypoxemia that is refractory to supplemental oxygen in a person that just doesn't look that short of breath, always think about shunt, because what Kirtan has told me thus far, unless the person is worsening before the picture, doesn't really explain enough to have respiratory failure to this degree that's about to get intubated.
Amazing reasoning sharing. Dan, I would like to ask you in terms of, because you elaborated on hypoxemia, how do you approach this?
I knew you were going to ask that. Hypoxemia is a very broad problem. And there's lots of people that go with the physiology by like hypoventilation or shunt or VQ mismatch, and that's just never really worked for me. And so I kind of try to group them by the presence or absence of parenchymal lung disease. So I think about hypoxemia with a clear chest, or I think about hypoxemia with something on the chest film or on the chest imaging. And to me, those are my kind of some of my first branch points, where if I have hypoxemia with a clear chest, I would think about hypoventilation. I would think about PE. I would think about sort of dyshemoglobinemias. And if I have stuff on the chest film, that's like a whole differential diagnosis in itself, right? That's pulmonary edema, hemorrhage, infection, scar, all that other stuff. So I don't have and for the clear chest, also shunt. I forgot to add that. So that's my abridged version of how I think about hypoxemia.
And what additional information would you like to get to make more progress in this case?
I think we need microbiologic studies. So I haven't heard about any sort of respiratory cultures or sputum samples in this case, but I suspect that she may not be expectorating, or she may be too sick. I worry that she's headed towards an intubation, which is certainly unfortunate, but also does actually allow for pretty easy access to the airways, either by bronchoscopy or by tracheal aspirate. So I have not heard. I definitely want to get that repeat picture. I don't know if she needs a repeat pulmonary angiogram protocol for this next one. This could just be a standard protocol CT, because I really want to take a better look at her parenchyma. Something that I think I didn't appreciate for a long time is that when we get CT pulmonary angiograms or pulmonary angiogram or CTPE protocols, we actually often do them on an expiratory phase. And so people's lungs tend to be squished, and it can obscure parenchyma or parenchymal processes. It can increase atelectasis. And so having sort of nice full lungs, if she's able to take a deep breath, is really what I'd like for this. But yeah, eventually I think we're going to need some sort of microbiologic studies in this case.
Someone is asking in the chat whether you would preemptively intubate this patient and do bronch at this point to avoid emergent intubation.
I'm not an intensivist. I think, many times on the floor, we do take care of people on high flow, and we're sort of wondering when we're actually going to do that, because I think largely it depends. If she continues to worsen and we don't have diagnostics, I think that's sort of the time where I would start to think about it. Plus, you now have 72 hours of trying to use treatment as tests with corticosteroids and with standard decent antibacterial coverage, which means that you're either dealing with something really bad that's non-infectious, or you're dealing with a resistant bacteria, which maybe she has, maybe she doesn't. And 3 is that you're dealing with a non-bacterial infection. So I think that probably she's rapidly heading in that direction, unless we get some data point to change, And as far as things like additional studies that we could want, there are things like serum galactomannan, serum beta-D-glucan. Those can be useful if you're as proxies for invasive fungal diseases, if you're truly not able to kind of interrogate the airways. Obviously, we want to, if she hasn't had this, I suspect she has, with prior TB infection and with immunocompromised, but testing for HIV as well. So there's stuff that we can send, but I think the money is going to be taking a look at her lungs again and getting some samples from her airways one way or another moving forward in this case, unless I'm missing something else.
Thank you so much, then. Kirtan, would you like to give us an next aliquot?
Perfect. So first I will show the images of day 5 when she was becoming worse, and then I will share the basic microbiology data. Just a second. All right. So as you guys can see that when I told you about the CT scan of day 1, all I said was that there was something in the left lower side, but this is on day 5. So you can see that now it's involving more area. I will also share other image. Second, the other cuts of the same CT.
So here we're seeing, again, multifocal ground glass and consolidated opacity. She previously had 1 effusion. Now she probably has 2, if I can see it from this angle here. And there just seems to be multifocal without a clear kind of predilection for one geographic area. And were those nodules at one point, like clustered nodules around in the first clip, sort of in that?
No, I think Dr. Restrepo, what you said first was like appropriate, that it was just GGOs, but no clear radiculonodular infiltrates, no infiltrates, just GGOs.
Okay.
And this is the sagittal section. All right. And now I will share the official read which radiologist gave us. Yes, so it basically says what Dr. Restrepo said, that there are bilateral effusions. Now, actually, the right one is bigger than the left one, and there are diffuse GGOs scattered across the lung parenchyma without any particular pattern. And at this point in time, since we were able to tell, we got all the studies from that effusion, and it showed that the total count on the fluid was 2,700, with neutrophils being 75%, lymphocytes 10%, and monocytes 10%. By the Light's criteria and calculating the LDH and protein ratio, it was exudative in nature. The pH of the fluid was within the normal limits. The glucose was also within the normal limits when compared to the serum. The adenosine deaminase levels was elevated at 41. In our lab, the upper limit of normal is 10. And the basic microbiologic studies, HIV, hepatitis B, hepatitis C, syphilis serologies, all returned negative. Sputum cultures, gram stain, bacterial and fungal cultures, AFB ×3, all negative. Urine Legionella, urine strep, also negative. Urine cultures, so far unremarkable. Blood cultures ×3, also unremarkable. And that's the end of this aliquot. Thank you.
So, so we had fungal cultures that were negative, fungal stains that were negative. We had AFBs from, this was, she expectorated herself. All right, and you had 3 of them that were all negative. You have, and then you have an elevated adenosine deaminase in the pleural fluid. So I think, you know, one organism we haven't been talking about that much, I think somebody was bringing it up, is this pneumocystis. You know, I don't think of Humira alone as a dead ringer for pneumocystis. Radiographically, pneumocystis can really do absolutely anything, but I don't think of it as something that causes pleural effusions. I don't think of it as something that causes bilateral pleural effusions. What I do think about, despite all of this negative TB stuff, is that TB is sneaky. And an elevated adenosine deaminase in the pleural fluid has been associated with pleural tuberculosis. Pleural tuberculosis is a incredibly difficult disease to diagnose. It typically actually requires pleural biopsy. So while we think about kind of you know, sending pleural studies for tuberculosis, they tend to be incredibly low yield. And for any kind of serosal TB, including the pericardium or the peritoneum, you really do need actual serosal tissue. So I am not fully convinced, despite, you know, that she is, like I said at the beginning, I think disproving TB is going to be really hard. Having said that, you know, it doesn't seem she has airways positive TB. So maybe it's going to be a little bit harder to get to a diagnosis here. What is probably a little bit less likely is maybe Aspergillus. We probably should have been seeing it here. There should have been an eosinophilia if this was that. It makes you start thinking about sort of inflammatory causes of these kinds of things, that maybe the 50 milligrams of hydrocortisone wasn't enough. So that is another thought, and given that a lot of the micro is negative here thus far. So, this is a good question, is like, where does this really lead us in terms of what else can we do and to get a diagnosis? There is obviously bronchoscopy, which in the presence of expectorated sputum doesn't actually perform that much better. But I think in the presence of this respiratory failure that she's kind of headed towards, I do think she's going to end up on sadly, hopefully not, but I worry that she's going to get intubated, and then we're going to have to kind of send diagnostics off of a bronch, or even maybe lung, tissue from endoscopic biopsy in these cases. So unless something else pops up positive, it does make you wonder. This is a tough case. I actually, you have a very sick person here that keeps getting worse on appropriate therapies. So again, I return to kind of the broad strokes reasoning. Is this non-infectious? Is this or is this non-bacterial? Is really where I'm coming from. And so with the elevated ADA, in theory, I believe it's also been associated with lymphoproliferative disorders. So could this all be pulmonary lymphoma? It seems very aggressive. Again, time course would also favor kind of recrudescent infection or de novo infection. So you guys decided not to be nice to me. I told you that you had to be nice to me. And so I am still worried about tuberculosis on some level. Call me crazy. Were the galactomannan and the beta-D-glucan ever sent? They were. That's another tree to bark up. If one of them is very, very positive, it would kind of shift you towards an invasive fungal infection. Again, things like cryptohistoplasma, the endemic mycoses, and the ubiquitous mycoses. We probably should have seen Aspergillus by now if that's really what we were dealing with. But certainly something to keep in the back of our minds. Again, a rapidly progressive infection or non-infectious process. I just think the diagnoses that we have, even though we have extensive ones, haven't really fully nailed the diagnosis.
And what I'm curious about, what are non-infective causes that cross your mind in this case?
So with multifocal ground glass, certainly alveolar hemorrhage, especially with the hemoptysis that she had. And you can think of alveolar hemorrhage as things that cause capillaritis, meaning that the actual pulmonary capillary is inflamed. That's things like vasculitis, all the renal pulmonary syndromes. Then there's kind of like bland hemorrhage, which is usually associated typically with folks that are on antiplatelets or anticoagulation that have an elevated, often an elevated wedge pressure. And I think of it just as like kind of a hydrostatic pressure that caused capillaries to burst and bleed in those cases. But again, she's not on any anticoagulant. She doesn't really have a reason for that. So if we were to get that bronchoscopy, we could see sort of serially bloodier aliquots that would suggest alveolar hemorrhage. So certainly that's a non-infectious cause of rapidly progressive respiratory failure. There's drug-induced pneumonitis as well. I don't recall her being on something that's super pneumonitic in terms of kind of classic offenders. And then there's sort of acute interstitial pneumonias and other kind of non-infectious, rapidly progressive parenchymal lung diseases that can cause respiratory failure, organizing pneumonias as well. So those are the things that I think we would have to invoke after really making sure that this person doesn't have either a mycobacterial infection or some other fungal infection that we have.
Thank you so much. Then Kirtan, we are excited for the next aliquot.
Perfect, sure. So this aliquot, let me tell you what happened. So firstly, regarding the studies which Dr. Restrepo requested, we did send the autoimmune serologist to rule out any inflammatory component, especially the diffuse alveolar hemorrhage. So ANA was obtained, which was unremarkable. Double-stranded DNA serology is also normal. ANCA, rheumatoid factor, anti-CCP, all unremarkable. Myositis panel was obtained, which was also clean. anti-GBM for good pastures and glomerular basement membrane disease that also were unremarkable. And even at this time, we kept on repeating UA, making sure we are not missing any pulmonary renal stuff. UA was clean times 3 or 4. So that is also cool. Now, what else? So since she keeps on declining, now we start thinking that, okay, could she have hospital-acquired pneumonia? So at this point in time, she is on vancomycin and zosyn. Steroids have been stopped at this point because the stress dose steroids were given for like 5 days and she was fine with it. While we are doing all of this, at one point, we did think that, okay, is it possible that she has pulmonary edema just because of like myocarditis or heart failure, something like that? So we got the transthoracic echo, ejection fraction normal, 60%, no diastolic dysfunction, no valvular issues, and no vegetations as well. So we ruled out those two aspects. And while she is still on the verge of getting intubated, somehow miraculously, she was still hanging around, like she was still not becoming sick enough. So fortunately, she was still there. And on day 8, she gets diffuse abdominal pain, 10 out of 10, along with nausea and vomiting. And I can show you what did the CT abdomen pelvis showed. And then I can also give you the official read. So here is the first imaging which I wanted to share. All right.
So very large transverse colon in this case, maybe going out into the sigmoid, some soft tissue in the sort of soft tissue edema in the body there. Doesn't look like free air anywhere. And that sort of descending colon there on the left, maybe I can't tell from this cut or not, but whether there's colonic thickening that's present there as well. I don't know.
You're on the right path, doc. Let me show you the second image. Right.
So yeah, very dilated, looks like cecum in this case, transverse down into the sigmoid area. Unclear, if there's air in the rectum, this would argue against a true large bowel obstruction. But if there is a very dilated sort of cecum there, or sorry, if there is no air if there is air in the rectum, you could think about something like acute colonic pseudo obstruction, or what's eponymously known as Ogilvie syndrome, which happens when folks are really, really sick, like she is in this case. I couldn't tell if that was a twisted kind of coffee bean sign of a volvulus, which would be the only other thing that can give you that acute sort of colonic twisting like that. So I don't think it was that, but that's kind of what it looks like to my eyes.
Perfect. No, you're on the right path, doc. So let me tell you the official interpretation. So when we got the CT abdomen pelvis, we also looked at the lower cuts of the CT chest, and it actually showed that at this point in time, the effusions are recurring. There are diffuse GGOs again redemonstrated. And the read on the abdomen pelvis was there is dilatation of the cecum ascending and transverse colon to the level of splenic fracture. And the cecum measures 9.6 centimeter in caliber. Stomach and small bowel are normal. There are areas of peritoneal and mild mesenteric fat stranding. There is also an area of peritoneal thickening and nodularity in the anterior aspect of ascending colon. So overall findings are non-specific. It may reflect pseudo-obstruction of the colon or Ogilvie syndrome, presence of an underlying abdominal or peritoneal inflammatory process cannot be excluded. And at this point in time, giving you a little bit sneak peek of what was going on in the labs. So a CBC count still somewhere in the same ballpark figure, like 12,000 to 15,000, 90% neutrophils, 5% lymphocytes. Hemoglobin is staying steady at like 11 to 12. Platelets are also holding around 250K. Liver function unremarkable. BU and creatinine normal. ESR, CRP barely elevated. And at this point in time, the 1,3 beta D glucan and serum galactomannan, both of them also returned negative. And that will be the end of this aliquot. Thank you.
Okay. So the whole story was like here. And now we're like broadening the CT scan. So it's like now it's from the sternal notch down to the pelvic symphysis, the pubic symphysis, right? And we have, I think that there's a lot there. Like I said, people that are in the ICU, they have like Ogilvie's happens, right? So people that get sick can get sort of acute distension. The question is like, is that colon, it's somehow restricted by these areas of thickening and enhancement and nodularity? And so when you think about those nodularity and all that other stuff that's there, you can think of one of two things. In an immunocompromised host, I'm going to sound like a broken record. This still could be disseminated infection, right? This could be serosal involvement of tuberculosis. This could be metastatic kind of fungal infection as well in an immunocompromised host. So it means that there is infiltration of the peritoneum and the mesenteries around all of those organs. So again, this still leaves something like tuberculosis on the table. The lack of the normal galactomannan really kind of makes invasive aspergillus infection in an immunocompromised host less likely, given all the other stuff that we know about in the chest. The negative beta D glucan is probably a useful test to say that she's not candidemic, that she is not, that she probably doesn't have pneumocystis. But many fungal species do not actually have beta D glucan in their cell walls. A notable exception is blastomyces, which she doesn't really have the epi for, and cryptococcus, which everybody technically kind of has the epi for because it's everywhere. And then the only other non-infectious thing that I really do think about in these cases is a lymphoproliferative disorder, or in theory, metastatic carcinoma can cause lymphangitic spread in the lungs and kind of all the stuff down in the pelvis. When I hear about kind of peritoneal thickening, that's often gastrointestinal or genitourinary, female origin malignancies that end up, like ovarian cancers, that end up causing peritoneal encasement. So, again, we were considering non-infectious things. I think malignancy we've kicked around a couple times here. Certainly, again, lymphoma and then certain carcinomas enter the ballpark, but I'm still kind of now worried that there is a disseminated infection that could have done all of this. Now, the problem is, how do you get to this diagnosis? Just like I said in the chest, tapping pleural effusions doesn't really help that often. Tapping ascites is equally as, not that useful. So in these cases, sometimes we have to go for peritoneal biopsy, which probably is safer to do than any sort of pulmonary biopsy in somebody that's not much respiratory failure. But I could easily see a surgeon say, there's no way I'm touching that person with a 10-foot pole while a colon is that dilated. And no gastroenterologist would probably want to go up there until the colon is a little bit more decompressed to get sort of tissue samples from the inside of the other way around. So I'm curious to see what happened here, because this is, we need more tissue, we need more diagnostics, and it's kind of tough to see which way to go.
Amazing reasoning sharing. I would just like to ask you, because we have so many information, whether you would like to frame this case for us and tell us what you're thinking might be, where would you put your, how can I explain it? Where would you say this is the most probable thing you're really thinking of in this case so far?
I think this case is really hard. And actually, so I would just say this is a 54-year-old immunocompromised woman from a hyperendemic region of the world for tuberculosis that's had prior tuberculosis, presenting with acute respiratory failure, and now with evidence of extrathoracic disease manifesting as peritoneal thickening and possible bowel involvement. So it's a multi-system process by definition. Again, I think about in this host, like I've been saying all the time, I disproving tuberculosis in an infection is going to be the critical before we even entertain any of the other stuff. As far as non-infectious etiologies, we have to think about kind of a multi-system metastatic malignancy, either lymphoma or the appropriate kind of carcinoma. As far as where we go next, again, I think obviously getting a piece of tissue either from the lungs or from the peritoneum or from the bowel probably is going to be the next place we go, because I think non-invasive diagnostics we've kind of really run out of. For the most part, important that when we send those tests that we actually get sort of AFB stains on them, and that we send them for mycobacterial culture as well.
Brilliant dissection. And Kirtan, would you like to give us some clues, hints, where the case went?
Perfect. So I can give the final piece of data, and then I will ask Dr. Restrepo to tell us the final thoughts that he has, and then I will reveal what happened. So at this point in time, again, things are not clear what's going on, and we are now day 13 or day 14. Blood cultures have been unremarkable. fungal cultures have been unremarkable. And this point in time, because of the reasons Dr. Restrepo mentioned, that sometimes 1,3-beta-glucan can be negative in some fungi, we got the serum crypto, plasto serologist, unremarkable. We got the aspergillus serologist, despite galactomannan being not remarkable, because we wanted to make sure we are not missing anything. So we got the aspergillus IgE, IgA, IgG, all unremarkable. Total IgE levels were also obtained, which were also within the normal limits. And just to clarify, the liver function test also, like stone cold normal, AST, ALT, alk-phos, bilirubin, LDH, all has been normal till this point in time. So now let me tell you that what was the way in which we got to the diagnosis. I won't reveal what's the diagnosis yet, okay? So what happens is this person was in ICU and there were some of my friends there and they texted me that, hey, Kirtan, we have a cool case if you want to take a look. So I was like, okay, sure, let me take a look. So I went there, I talked to the patient, I looked at the chart and everything. And I'm thinking to myself that some of the clues that I could get from this data is that firstly, this person has so-called IBS. And we know that, okay, IBS is something which is very easy to tag onto something. But what if that IBS is actually not IBS and something else like, okay, diarrhea, constipation, but maybe it's something more than that. Secondly, the team was thinking that maybe this obstruction is all because of the opioids. Because remember, she has fibromyalgia. She was on like tons of ketorolac, morphine, hydromorphone. But here is the deal that in somebody who doesn't have volume overload, whose albumin is normal, no heart failure, no cirrhosis, where is that all the thickening and nodularity coming from? That it cannot be artifact. That peritoneal thickening and nodularity has to be explained. So I was thinking that, okay, I have one pivot point in that margin, that something is in the gut wall itself. Second is this IBS stuff. And finally, when she came to the hospital, all she had was like subsegmental PE and mild diffusion, mild consolidation. But she really started getting worse after she got the stress dose steroids. So there is another clue that if this was some sort of, let's say, DAH or any other like pulmonary alveolar proteinosis or something like that, you would expect at least not worsening. Maybe it would stay the same with steroids, but it should not really worsen like this. Like now you have GGOs all over the place, so which is also kind of tricky. And all this time, there is no lymphadenopathy anywhere in the body, not in the mediastinum, not in the retroperitoneum, nowhere. So all the endemic mycosis, all the tuberculosis, you kind of start wondering that, what should I do with that? Like, is it really one of those infections or not? So these were my pivot points. And then I told the team to obtain, like as they say in CPC, right, that a diagnostic test is performed. So it was both invasive as well as non-invasive. And finally, we got to the diagnosis.
Yeah. So obviously, I think I still am standing by my read of this. I think we need tissue. I think we need tissue to both disprove a metastatic infection as well as a metastatic malignancy. And so I think in these cases, probably the safest place to biopsy is where we should start. And so, you know, if her colon is safe to do it, we could take a look from the inside, make sure there's no colorectal carcinoma, as sort of like a nidus for a large bowel obstruction. I don't know if a surgeon would touch her, it's a peritoneal biopsy is an alternative site, and then obviously all the stuff in the lungs. So, you know, that's probably where we'd land here.
All right.
Kirtan.
Yeah. So maybe, you know, before I reveal something, maybe I can ask Dr. Restrepo just even once more that, remember, Dr. Restrepo, you were asking about the eosinophils initially, right? Now, let's say that eosinophils were indeed little bit elevated. Then what would you be inclined towards?
You know, certainly with eosinophils and a person coming in that's immunocompromised, there are all of the infections that we've been talking about can be associated with eosinophilia. One thing that we haven't really been talking about in terms of her epidemiology here would also be strongyloidiasis, because it can cause respiratory failure and bowel wall pathology and lots of other things. So many times that we're talking about respiratory failure would be the presence of would usually kind of be in strongyloides hyperinfection, in which you have kind of migration of actual helminths through tissue planes, and you have the auto-infection cycle of it that can result in sort of eosinophilic pneumonia and marked respiratory failure and shock. So that's one thing. They don't have to have eosinophilia. Many of them many of them do in these cases. And she is from an endemic region from it, and that does also get worse with steroids. But it would be pretty humbling if that was the actual diagnosis. I retain the thought process up until now. The other things that eosinophilia can be associated with is lymphoma, certain metastatic carcinomas as well. So that's kind of where my thoughts are.
Perfect. So Dr. So you actually got it. So that is what so now firstly, eosinophils have always been normal, stone cold normal, always. But as you rightly said, that many times that eosinophils are not, in fact, like the data suggests that like less than 50% of people have actually have high eosinophils. So that's what I was thinking. I was telling my friends that, hey guys, this person has been on adalimumab, you gave tons of steroids, has IBS-like symptoms. Now, what if it was actually parasite? And now that you give steroids, everything is busting open and there's peritoneal thickening, nodularity. And of course, she won't respond because she has been on all the antibiotics, but not on the right medication. And remember, as you were saying, that there is this Venn diagram of asthma and stuff. So we always think of asthma plus syndromes. So one is EGPA, one is ABPA, third is cardiac asthma, and finally fourth is the parasites, because as we know that parasites can cause Loeffler syndrome. So I was telling them that what if all these GGOs which you are seeing is actually the Loeffler component, which can happen when strongyloids are migrating through and through. And maybe that is causing all this hypoxia, infiltrates, and we are not targeting it. So I said that maybe we should get strongyloids. So we got the strongyloid serologies, and there it was. It was positive, strongly positive. And strongyloids assay which we use is enzyme immunoassay, which is very, very sensitive and specific. And in right setting, in somebody like this who has been on steroids, who has these IBS-like symptoms, bowel symptoms, it perfectly makes sense. So finally, we gave ivermectin, and boom, like for 2 weeks, she's in ICU. One day, she's out of ICU. Effusions go away, infiltrates go away. So we never even actually required to do the bronch, because like there was nothing to bronch. Like the infiltrates went away, effusions went away. There is nothing that needs to be done. And finally, also the point which Dr. Restrepo highlighted, I wanted to mention, as he rightly said, that ADA levels are not just for TB. And I think even in the chat, Justdeep mentioned this, that in fact, most of the studies suggest that the levels of ADA matter more when you have lymphocytic effusion, because ADA is an enzyme which is present in abundance in neutrophils. So whenever you have neutrophilic effusions, the ADA levels really cannot swing you one way or other. In this case, if you remember, our patient had like 75% neutrophils. So the ADA levels really couldn't tell you about TB. It's probably more suggestive of something else like lymphoproliferative disease or parasites. And regarding the parasites, another important clue is that if you are on adalimumab, if you are on steroids, you are suppressing it to so much extent that even if there was a real hyperinfection, you won't see eosinophilia. So often eosinophils could be missed. So which was another teaching point. And then final teaching point which I wanted to mention was that whenever we give somebody cytotoxic chemotherapy and steroids, we always say that let's screen for HPV, HCV because they can reactivate. But we never think about strongyloids. And in fact, the IDSA guidelines, Infectious Disease Society of America guidelines are clear that in any person who is going for hematopoietic stem cell transplantation, in any person who is going to get prednisone for long term or for TNF alpha inhibitors like this lady has been getting, they need strongyloid screening. Even if they are not from endemic countries, you need screening. And in fact, authorities suggest that since ivermectin is such a simple drug with no side effects, just give ivermectin even if you can't screen for strongyloids. So that's how strong the indication is. And this case is a starking reminder that how in amidst of everything, things could be missed, like these subtle points like IBS, patient is on steroids, now it worsening GGOs because eosinophils are not there, but they may not be there. So finally, that was the case. And it was very satisfying that finally patient improved, went home. We gave ivermectin as per the standard protocol. So like 2 doses on one day. And then after 14 days, you give another 2 doses because patient is immunocompromised. And hopefully she will be doing fine for rest of the course of her therapy.
Wow, Kirtan, it was brilliant. And Dan, thank you so much for this brilliant discussion. I wanted to ask you whether you would like to share your reflections on this case.
Yeah, I think it's I think the humbling part of this case is that she didn't show up with hyperinfection, right? Hyperinfection looks and smells a certain way. And I think that she sort of started to develop it while she was in the hospital course. And I think that those are often the challenging ones, because you're not sort of you're sort of looking at it. It's most useful to think of syndromes, at least in my mind, as like when I'm meeting the patient, what's been happening. But whenever you get new data that you have to respond to so iteratively, especially in somebody that's so sick, it gets really difficult. And I think like changing gears there is actually tough. And this was a really humbling case. So obviously, you know, Strangi is not like super common. And so certainly in immunocompromised people, it's important to keep on the differential. And I think, you know, I think if, as Kirtan said, if it had been framed with eosinophilia up front, it probably would have been a lot easier to chase down. So the fact that, you know, because when you think about it, the worsening on steroids, again, can also be, I've seen TB get really bad really quickly on steroids. Other fungal infections kind of really light up on steroids. Perhaps the degree with which she failed and then she got worse is an important tip off in a person that is from a hyperendemic region, even if they don't have eosinophilia. I think that's probably the learning point.
Thank you so much. I just wanted to highlight a comment that is brilliant is even an underestimation. And before closing the session, I wanted to ask you, Dan, whether you could highlight 3 favorite teaching points for the listeners out there.
Think about Strangi. Think about Strangi, and then always think about the host, right? Like this is an infection until proven otherwise in somebody that looks like this. What flavor of infection, I think, is you know, is your job to figure out. But like, even in the face of normal data, you should not be reassured if the host is concerning and they're not getting better. So that's probably what I would say are the takeaways for me.
Thank you so much, then, Kirtan. Dan, thank you so much for being here. Then I will close the session, and yeah, thank you so much also, Mukund and Parisa. Mukund, thank you so much for typing all of this. I know how hard it was, and Parisa for your brilliant teaching points. Then please take care, everyone, and see you soon. Bye.